Good evening, everybody. Welcome to this BTOG webinar on the update of ASCO 2020 in just 1 hour. My name is Tom Newsom-Davis. I'm a medical oncologist from Chelsea Westminster Hospital and delighted to be Vice Chair of BTOG and your host, ladies and gentlemen, tonight. First thing to say is we thank our sponsors of BTOG for helping support this webinar series, particularly important in an ASCO update to say that they do not have any role whatsoever in what is planned or what is presented as entirely independent, as you might imagine. BTOG is an organization we love dearly, as indeed we do Dawn and Gina, who run the show. So if you'd like to be in contact with us, here are email addresses and website. And if you're not a member, why on earth aren't you a member? Please do sign up. So we would love you to submit some questions. We try to rattle through the presentations reasonably swiftly and then have about 15 minutes for questions and answers. I think it's always the best bit. So please do tap them into the Q&A panel on Zoom. It will appear as if by magic. And then you can send your feedback, and in return, you get a shiny certificate of attendance, which is all recognized by the RCP, if that's the kind of thing you like to do. So here is our agenda and our panel and our 3 speakers covering immunotherapy for lung cancers, mutation-driven non-small cell lung cancer, adjuvant, neoadjuvant, and locally advanced. Before we kick off, I just want to say one thing. When we announced this panel, it was noted, as we had noted, it is an all-male panel, and that did create some reaction on Twitter. We are, of course, very, very aware of this, and we're very aware of people's feelings and take that very seriously. But I would just say that when we are trying to do all of our BTOG activities, we're very mindful of our need to be inclusive, and we do so based not only, of course, on gender, but also race, geography, tumor type, speciality, and region, including devolved nations. And that's particularly challenging to always get complete representation. And that's even more the case in ASCO, when, of course, we are dependent on people actually being at ASCO. It's a difficult meeting to get to. Being able to commit to several hours to create these talks in between ASCO and this meeting, and actually being able to make this date as well. So although we never want to have any panel where any one particular group is excluded, and we absolutely take on board people's comments, in this situation, it was unfortunately unavoidable. That being said, we're going to move on to our first presentation. I'm very grateful for the assistance of Alistair Greystoke. Ali is a senior lecturer and medical oncologist at the Sir Bobby Robson Clinical Trials Unit at the Freeman Hospital in Newcastle. And Ali is going to take us through immunotherapy updates in thoracic cancers from ASCO. Ali, the floor is yours.
Thanks very much, Tom, and thanks very much to BTOG for the invitation. As Tom said, this is going to be a little bit of a whirlwind and just some highlights of what I thought were interesting and might perk people's interests. Those are my disclosures. So I guess the question is, everyone's asking, is this going to be practice changing from point of view of our immunotherapies? We've had lots of changes over the last few years. And I guess these are key questions that when I go to ASCO, I want answered is, are there new agents coming through? What should be our optimal frontline treatment, both small cell and non-small cell lung cancer? What we do in the situation where patients have chemotherapy and immunotherapy up front and they progress, do we have any good options for them? And also starting to look at some of the more difficult populations that aren't always enrolled in the pivotal studies, and we'll see some data as to those as we go forward. So I'm going to start with the bad news first, which was the presentation of the Skyscraper 2 results. So many of you will have seen this. This was a phase 3 study in small cell cancer, looking at adding in a new drug into our standard regimen of carboplatin, etoposide, and atezolizumab to patients with extensive small cell. So trying to see if we can improve outcomes. And so this was a 500-patient randomized phase 3 study. Patients had to be fit, and they could have brain metastasis, but they couldn't have any symptoms. And they received what we would regard as standard treatment with carboplatin and etoposide, going on to maintenance atezolizumab, with or without a monoclonal antibody that targets another checkpoint called TIGIT. And this was on the basis of some provocative data in non-small cell, lab data, and phase 1 data. And it's one of the most negative studies, unfortunately, that we've seen. You can see that both the PSF curves and the overall survival curves basically completely overlapped. It does give us, the only good news about this study was that the median survival in both arms was just over 1 year, which is the first time that's been sort of seen in a phase 3 study in extensive small cell lung cancer, but a completely negative study. So there was a little bit of criticism on Twitter about the move straight to phase 1 to phase 3 without a phase 2 study. I think that's unfounded. I think we can talk about how important survival endpoints are in immunotherapy studies, and this study recruited very quickly, and we'll learn a lot from it. I don't think we should extrapolate from the small cell studies to the ongoing non-small cell studies using this drug targeting TIGIT and other agents targeting TIGIT. I think the immune environment in small cell is very different. But I do think we do now need to move forward of just adding in another drug and hoping it's going to work. There is increasing data that small cell can be stratified by biological type, and that some of these are more prone to, more vulnerable to treatment with immunotherapies than others. And there's some interesting new agents coming through that we can maybe talk about in questions. So I'm afraid that was about it for small cell in terms of practice changing a negative study which didn't change practice. The next question is, well, what should we use in the frontline setting? We talk about this all the time in our clinics. If you have a patient with high PD-L1 non-small cell lung cancer, we have access in the NHS to both chemotherapy, immunotherapy combination, or a single agent immunotherapy. So this was a pooled analysis from the FDA looking at over 12 studies that had been submitted to them for licensing, where either chemotherapy and immunotherapy had been compared to platinum doublet chemotherapy, or single agent immunotherapy had been compared to platinum doublet chemotherapy. So there were some differences between the studies. Some of the studies used nivolumab and ipilimumab, so 9LA and Checkmate 227 were in there. But overall, there was over 3,000 patients and over 1,600 that received immunotherapy. So a very useful resource, and where they've got patient level data. Not hugely representative of our real world population. So it was highly biased towards males, 65% males, very little in the way of people over 75, only 11%, and very Caucasian driven. But taking all that with a pinch of salt, you can see that overall there wasn't any difference statistically in overall survival. Hazard ratio close to 1, slightly higher with the medians of a couple of months. What there was a difference for, and I've plotted this myself because it wasn't plotted in the talk, was you can see there's a higher response rate as we might anticipate, and a slightly better progression-free survival, although again, this did not make statistical analysis. I think what is helpful is looking at the forest plot, and you can see that the patients who seem to maybe not benefit so much from the addition of chemotherapy was the over 75s, or a very small population. And those in particular who do seem to benefit are the never smokers. And so this is my view. On the left, I've shown the recent real-world data that was presented, recently published in Annals of Oncology, looking at a very similar question, and again showing no survival benefit of using chemotherapy, immunotherapy over immunotherapy in the frontline setting, except on the forest plot again in never smokers. So I think our default now should be single agent, except where we have never smokers, and you need to make sure those are fully profiled to make sure you're not missing the non-gene-driven cancer, as we'll hear from Yaz. And maybe the younger patients, and maybe when you need for response. But there are phase 3 studies that will help inform this. But for the present, I think that is now my view. And then there are a couple of studies looking in the second line setting as to what we should do in patients who have progressed on chemotherapy or and or immunotherapy. I'm going to show one of them, but I'll highlight the data of the other one. So this was a randomized phase 2, a relatively small study, just over 100 patients. And this was conducted within the lung map study, which was a bit like our national lung matrix study, where they were looking for personalized therapy. But if you didn't have a personalized therapy, then you could go into this arm where you were randomized either to investigator's choice or to treatment with pembrolizumab again, so immunotherapy again, and a monoclonal antibody against VEGF, ramucirumab. Now, there were some imbalances which you can sometimes have when you have a relatively small study like this. So both performance status, PD-L1, and tumor mutation burden all did favor the investigational arm. So we do have to bear that in mind when we're looking at these results. And to be this, you had to be fit, and you couldn't have had early progression on either chemotherapy or immunotherapy. So they were getting rid of the worst population. So this study did meet its survival endpoint. You can see an improvement in median survival by 3 months with a hazard ratio of 0.69, which I think is certainly interesting. You can see there the standard of cares that were received. So a number of patients received ramucirumab anyway, but in combination with chemotherapy, docetaxel, and that's the sort of standard American second-line treatment. and then a few others, but also do know that 6 patients didn't receive any treatment at all, just went on to best supportive care in the non-investigational arm. Interestingly, there was no difference in response rate between the 2 arms. You can see the response rate was at 22%. Duration of response, however, was longer in the arm with immunotherapy, and I've shown you there on the right the progression-free survival curves, and you can see that's maybe this is all very driven by the tail, 10 or 15% of patients who are still responding to the immunotherapy. So what does this mean? Well, there I've done a little table showing you the response rates, the progression-free survival, and overall survival of this study, the investigator choice, the other post-IO study that was presented using another, like an oral anti-angiogenic, and also some real-world data using nintedanib and docetaxel. And I think what's interesting is that the first and third do seem to have improved survival, but actually if you look at response rates, they're all relatively high and relatively similar, and higher than we would standardly anticipate with things like chemotherapy in the pre-IO era. However, it's very difficult to know who these people are, what their previous response rate was to immunotherapy, how long they had. And so to me, I think the best treatment is still unclear. I think the main thing is that when we're talking to patients about nintedanib and docetaxel, we can say that response rates do seem to be better than historically, but I still feel that this is a space where we don't quite know what to do, and we still need better treatments. And then I'm going to spend just a little bit of time on a couple of studies looking at difficult populations. So this was an updated study called the ATESO Brain. So this was looking, it's a relatively small study, treatment-naive non-small cell lung cancer, untreated brain metastasis, any PD-L1, but couldn't have an EGFR or an ALK. So this was a 40-patient study. They couldn't have any neurological symptoms, but they could be on DEX and anticonvulsants up to 4 milligrams a day. And they were treated with carboplatin, pemetrexed, and atezolizumab. And there was a number of endpoints, including safety, progression-free survival, etc. So I have included the baseline data for trials, but actually, if you look at it, this was a pretty good real-world population, at least for a trial. So most of them were patients with performance status 1, and on average, they had 5 brain metastases. So this is not a super selected population. And what you can see is that actually the response rate in the brain does seem to match up very nicely to the systemic overall response rate at over 40%, which is what I would normally quote for chemotherapy and immunotherapy in combination. If you look at progression-free survival, very similar between the extracranial and intracranial disease, maybe slightly worse in the brain. And if it did progress in the brain, they could have radiotherapy and continue on study. And you can see overall survival in this population with brain mets of up to close to 12 months. What was interesting is, as you'd expect, patients who had PD-L1 positive tumors did better than those that didn't. But what I found is very interesting is that those patients on steroid at baseline did just as well as those who didn't need steroids. And so, I think this is an impressive response rate, higher than we'd expect. There's a meta-analysis there of single-agent immunotherapy in brain disease. A lot of these patients had very small disease and were not on steroids, and the response rate there is about 17%. This was a real-world population. It was certainly safe. They didn't see any excess toxicity. Should we be extrapolating this to carbo-pembro? Using just a different immunotherapy, or should we be looking at the ABCP regimen using bevacizumab, which may also be useful in brain mets? And again, unfortunately, not a huge amount of detail on this about the differences between PD-L1 expression, squamous versus non-squamous cancer, and certainly of interest to me would be the time to radiotherapy. And then the last study I want to talk to you about, again, in difficult populations, either those who are not fit or those who are older. So this was a French study, and interesting study design, either randomizing to a platinum doublet chemotherapy with or without maintenance, or nivolumab and low-dose ipilimumab, a bit like the regimen that's coming forward in mesothelioma, although the nivolumab was given every 2 weeks. And so to go on the study, you either had to be older, and that was described as 70, and we can talk about that in questions. And if you're over 70 and or performance status 2, okay? And yeah, the primary endpoint was survival. And so the interesting thing about this was that depending on which group you were in, we saw that the curves were completely the other way around. So in the overall survival patients, the overall survival in the older patients over 70, if you were fit, they did much better with dual agent immunotherapy than with chemotherapy. But if you were performance status 2, actually you did better with chemotherapy than with dual agent chemotherapy, sorry, immunotherapy. So, sorry, let me try that again. If you're old but fit, you do better with immunotherapy. If you're unfit, then you do better with chemotherapy than immunotherapy. And this leads me to reflect on the performance status 2 population, which is really challenging, and trying to work out whether we should treat these patients with immunotherapy or not. And we've previously seen the PEPS-2 study in the UK. So here I've shown an Italian study which was in performance status 2, and what was interesting in the patients who were performance status 2 due to comorbidity, they actually did really well with immunotherapy. But if you're performance status 2 due to tumor burden, then you do really badly. So maybe not all patients with performance status 2 are the same. So in terms of difficult populations, I think we can consider giving chemo-IO in patients with brain mets, even if they require steroids and if we're allowed. Older patients with cancer can do really well with immunotherapy, even be it single agent or combination. There was a really nice presentation I've included for purposes of time from Notch, looking at pre-existing autoimmune disease and chance of flare, and I'd advise you to look at that. You can have an informed discussion. But patients who are performance status 2, it really does remain a challenge, and it may depend on why they're performance status 2. So overall, in that quick whirlwind, I think I would describe ASCO 22 for my patch of immunotherapy in stage 4 as not really practice changing, but it probably has helped refine my practice. Thank you very much, and back to Tom.
Ali, thank you. That was magnificent, and you get a gold star for being under 15 minutes. And I asked my fellow panel members to take note of his efficiency. So there's lots of things which have cropped up to my mind. There's some questions rocking up in our Q&A box, so keep on sending them through. The very best and maybe the very, very worst will be selected for discussion. We're going to move on to Riaz Shah. Riaz is a consultant medical oncologist, friend of the show, friend of BTOG, and great support of our organisation. He's a medical oncologist in the beautiful Kent Oncology Centre, and he's going to tell us about mutation-driven non-small cell lung cancer. Riaz, take it away.
Thank you, Tom. Welcome, everyone. My disclosures. This is designed to be relevant to UK practice, and obviously practice standards do vary around the world and even within our devolved nation, so please be conscious of that. Now, there are 8 FDA-approved actionable mutations, 9 if you split EGFR into exon 20 insertions and the rest. Every single one of these is available, in theory, in your national test directory. Every single one of these has a licensed drug within our country and is reimbursed in NHS England. However, I'm very sad to report that access to drugs and appropriate genomics is highly variable across our nations. The particular outliers are Scotland and Northern Ireland, where access to biomarker testing is not universal. And we've got a really odd situation. We've got a situation where sometimes drugs are available, but not the companion diagnostic, so you could never diagnose it in the first place. So this is clearly an unsatisfactory situation. So with that background, I want to introduce this study to you, Abstract 99022. This has come from the University of Pennsylvania, Dr. Agarwal's team, and they've looked at comprehensive genotyping in a retrospective study. So we know NGS on tissue detects mutations. We know that circulating tumor DNA also tests mutations, and we know that if you do both, you detect more mutations. Well established. What they did is a retrospective series of 335 patients who had molecular testing, and they looked at the patients in whom all 7, at that time, there were 7 FDA approved, all 7 results were known. And what they found is that 87% of patients had full comprehensive testing. And your chances of having comprehensive testing were way higher if you'd had tissue and plasma NGS as opposed to tissue alone. The other thing they showed is that patients that had comprehensive testing had a better survival, median of 22 months over 11.6 months, looking at patients who had incomplete molecular testing. And even more importantly, if you looked at all of the patients who just had comprehensive testing, The survival was even better in those where all of the results were known before any first-line treatment decision was made. So this is really powerful data. I think this is the final nail in the coffin for people that are denying the importance of genotyping in lung cancer. Upfront comprehensive genotyping should be standard of care. And what does that look like? Tissue NGS, DNA, RNA panel, ctDNA. This is a rallying cry for our community. Devolved nations need to act together on this. And even in NHS England, where the GLHs are established, reflex testing is not standardly available. There are huge disparities. And this is the only thing I want you to remember for what I'm saying. And GLHs have medical directors who are responsible for delivering this. So if you're not getting reflex testing at your center, you know who to talk to. Right, you don't need to remember anything else that I'm talking about. Let's talk, I'm going to whiz through a few things very quickly. So EGFR, what happens after osimertinib? Well, we know lots of things happen, very complex acquired resistance pathways, new on-target mutations like C797S, MET amplification, small cell transformation, chemotherapy. I want to introduce this study to you, the Chrysalis-2 study, using a bispecific MET EGFR antibody called amivantamab and lazertinib in patients who are progressing after osimertinib and chemotherapy. Amivantamab already has a label in exon 20 insertions, and lazertinib is a T790M active brain penetrant third generation TKI. And what was presented is data from a cohort of common mutation patients who've been previously treated, multiply treated, 40% with brain metastases, 33% overall response rate by investigators, blinded independent review, investigator assessed 28%, and you see all subgroups seem to have a similar result. So interesting, this is the waterfall plot. There was brain activity with clearance in a large number of patients who had brain metastases going into this study. Where is this going? Well, we're all awaiting the results of the Mariposa study. So this is treatment naive patients who are randomized to three arms, I beg your pardon, one of which is osimertinib arm B, and the other arms are ami lazertinib, and then lazertinib on its own. Arms B and C are blinded, double blinded. So let's see where that's going. I'm going to move very quickly on to MET, completely different Knight's move now. MET is really complicated. All sorts of things can happen in MET. Overexpression, amplification, fusions, and something called exon 14 skipping mutations. And it's a common mechanism of acquired resistance to multiply actionable pathways. So what is an exon 14 skipping mutation? An exon 14 skipping mutation is basically you get substitutions or indels happening flanking exon 14 of the DNA code for the MET gene, and it results in complete skipping of exon 14. So the protein that gets transcribed, the receptor, lacks the bit of protein encoded by exon 14. So what does that encode? Well, it encodes a particular motif that is important for ubiquitination, which is a mechanism of degradation. So basically, MET exon 14 skipping mutations mean that MET is stabilized, it isn't ubiquitinated, it isn't it doesn't get removed from the cell, and it promotes cellular signaling. And we know that this happens in a small number of lung cancer patients, and we've got 2 licensed drugs. And the Chrysalis study looked at the drug we've already talked about, amivantamab, as a single agent in a dose escalation fashion to look at its activity in MET exon 14 skipping mutations. And it has some activity, 57% response rate in treatment naive, 33% in the overall population. You can see these spider plots, look at the blue dots. The blue lines are patients who have responded, and you can see some patients have very durable responses with rapid responses. So interesting, not licensed. Important issue about MET toxicity is hypoalbuminemia and peripheral edema. Edema are common class effects of MET inhibitors. And with amivantamab, it's well recognized that infusion reactions can occur. There is talk of a subcutaneous preparation of amivantamab that has much less of that. I'm now going to move to something completely different, KRAS. So there are 3 studies in KRAS I want to just briefly go through very quickly. So this is an FDA pooled analysis. What they want to know is, do KRAS mutant patients behave any differently to KRAS wild-type patients when they're given immunotherapy or chemoimmunotherapy. And this is a pooled result of 12 randomized trials, 12 registration studies comparing chemo to IO or chemo to chemo-IO. And they basically did a big meta-analysis, 8,888 patients in total in all of those trials, but only 1,430 had KRAS status documented. And what you can see is in the top of this table that the PD-L1 split in the KRAS mutant patients is pretty similar to the KRAS wild-type patients. You can see that the overall response rate in patients who are having chemo-IO is the same, whether they're mutant or wild-type. Whether if they're having IO alone, there is no difference, and if they're having chemo alone, there is no difference. Notable, numerically, the response rate seems to be higher for chemo-IO. If you look at survival, again, no difference with chemo-IO, chemo alone, or IO alone, and you can see the curves are all overlapping. So basically giving us confidence that KRAS mutated patients behave very similarly to either IO or chemo-IO. But there does seem to be a suggestion that chemo-IO is a more effective, more appropriate treatment for these patients if they're fit enough. So that's that. The next thing about KRAS patients is about acquired resistance. So we already have sotorasib available as a result of this study, CodeBreak 100. And this is a molecular analysis from the CodeBreak 100 trial where they got 67 lung cancer patients and they did circulating DNA before entry into the study and then when they progressed. And what they found is that 28% of patients developed some sort of genomic alteration. Some of them were compound mutations. And if you look at these mutations, you see a wide variety of things, including EGFR mutations, MET mutations, FGFR2, ROS1, but many of these are potentially targetable. And so what they're building is a very complex pathway. And this is important because I think this is going to give us avenues of potentially future targeted therapies to rescue patients who become resistant to KRAS inhibitors. And this is very much the flavor of the month across the tyrosine kinase family of receptors, where we have multiple treatments that we're now giving patients. We're seeing complex multi-mutation mechanisms of resistance, and we're working out how we're going to tackle these. So in the future, we may be able to deliver personalized approaches to overcome resistance, and ctDNA technology is going to be key to delivering this degree of complexity due to the difficulties of tissue acquisition. The last thing I'm going to talk about in KRAS is a new G12C inhibitor called adagrasib. We already have sotorasib or sotorasib, whichever way you want to pronounce it. This is a drug that's given BID in capsule form. You have to be fasted, and the data is very similar to sotorasib. Response rate 43%, rapid responses within 1.4 months, median duration of response 8.5 months. So it all looks very interesting, but what was nice about this is they had a bit more clarity on intracranial response. So intracranial disease control rate was 85%. From the CodeBreak 100 study, sotorasib 88% was presented at World Lung last year. So it seems like we've got two drugs now that are potentially very similar. So KRAS patients respond to IO or chemo-IO, probably favors chemo-IO. Multiple mechanisms of acquired resistance are now recognized, and some of these may be potentially actionable, and adagrasib is likely to be approved in the future. And the last gene I'm going to talk about is this one, NTRK, the holy grail. So we have entrectinib and larotrectinib approved for this rare subtype of lung cancer. We had updated results on both. So this abstract is giving updated efficacy data on entrectinib, 150 patients. The BICR response rate is 61%, and it's 54, 25, and 70% in track 1, 2, and 3 respectively. The response was independent of the number of previous lines of therapy. Median duration of response 20 months. Median survival 37 months, intracranial response rate 69%, and manageable toxicity, so treatment-related adverse events leading to discontinuation 7%. So entrectinib very active. Another abstract looked at larotrectinib, This is the one that we have on label, 100 milligrams twice a day, much smaller number of patients, but very similar data. Response rate of 83%, median overall survival 41%. No treatment-related adverse events leading to discontinuation. So very interesting there. A couple of other things on NTRK that I thought were interesting. This was an abstract looking at larotrectinib and quality of life. And I'm told reliably that these curves imply that patients who were given larotrectinib had rapid and sustained quality of life improvements. And I've no doubt that that is indeed the case. And then this last study, which I think is really interesting, is a retrospective review of the Flatiron database. So this is a massive US database of real world data patients. And they looked at all the patients that had TRK fusions and split them into patients that actually got a TRK inhibitor and those that didn't get a TRK inhibitor. And those that were treated with inhibitors had a median survival of 39.7 months, very similar to the updated efficacy data from laro and entrectinib, versus those who had the fusion but didn't get treated, 10.1 months. So really important. It means if you find these patients, you can dramatically turn their lives around by treating them with a TRK inhibitor. It's critically important to detect these patients. We must find these patients. If you don't look, you will not find. Most of us are using RNA panels to detect this. They have very high failure rates, and we need to work very hard to reduce those rates. And there are well-recognized systems to try and achieve that. So in summary, this isn't really personalized medicine. This is about making a correct diagnosis and starting patients on the correct treatment. And that's all I've got to say. Thank you.
Well, that was magnificent, Riaz. You get 2 gold stars because you did it in less than 15 minutes. This is unheard of. And I think you're right about both the presentations so far, which there's lots of stuff there, and it may not be practice changing, but I think practice refining is definitely the word of the day, along with ubiquitinization, which I can't say. Our final presenter is Jerry Henner. That's Professor Jerry Henner to you and me. Jerry is a professor, as I mentioned, at Queen's University in Belfast, recently returned, having been the Director of Radiation Oncology at Peter Mac in Melbourne. We're delighted he's been brought back to the UK for the rain and the weather. And Jerry's going to update us on adjuvant, neoadjuvant, locally advanced. I think is probably the area in lung cancer where the really exciting data is. And so Jerry, take it away, the floor is yours. And don't forget to turn your camera on. Jerry, are you there? Hang on one second, we're just going to try to rescue Jerry. Matt, I think Jerry's struggling to, there we go.
There we are, that's great. Thank you very much. Thanks, Tom, and thanks for the welcome and introduction too as well. Now, hopefully the 15 minutes will only start from this point, not before. And thanks for asking me to do this presentation on adjuvant, neoadjuvant, non-small cell. Those are my disclosures, none of which are relevant to today. And we're going to just talk through those 3 topics, starting off, of course, with adjuvant. Before I do that, I just want to show this lovely timeline, which I borrowed from Dr. Patel from Northwestern University. That really is a lovely summary of where we've come from over the last 2 decades in lung cancer. I thought it was one of the nicest slides depicting the progress we've made, but how much is expanding and exploding in our world and how hard it is to keep on top of everything, as you've seen from some of the previous presentations. So looking forward, here's ASCO, and we're looking forward with neoadjuvant therapy, if you don't mind the association. And this was just an update, a reanalysis of Checkmate 816. Checkmate 816 was a study looking at neoadjuvant nivolumab and chemotherapy after people who'd had resectable stage 1B to 3A non-small cell, seeing did nivolumab and chemo improve survival over chemotherapy. And of course, that was a positive trial that's been presented previously. This is comparing the pathological analysis. And what was very interesting on this is to show that the pathological analysis was very highly associated with with patient outcome, both in terms of event-free survival and overall survival, therefore saying, look, pathological response really predicts very well for how you do in this regard. So I think what this is going to be used is probably tailor future studies in this regard. And that was by regardless of stage of disease and other baseline factors too as well. And this is by PD-L1 expression, still a separation in the curves here too as well. One interesting caveat that was discussed about this study was the type of chemotherapy used along with nivolumab, and it's worth saying that people who had carboplatin, when you look at this, really seem to do better. If you look at the top graph, event-free survival, they seem to do better that had carboplatin, and that was usually with carbotaxol as the chemo regime compared to cisplatin-based regimes. And then the question is, why might that be the case? Is it the carboplatin or is the carboplatin the Taxol? And that certainly was an interesting question. We obviously, of course, still haven't fully answered that in other stages of disease. Another interesting neoadjuvant study was the NeoScore study. This was looking at sitalutinib, which is actually a PD-1 antagonist, and this is a study from China. This looked at giving 2 cycles of sitalutinib alongside chemotherapy versus 3 cycles of the same regime, and looking again at pathological responses as a surrogate for outcome or indeed for survival. And if you look at it here, here's the pathological response rates: 26.9% MPR with 2 cycles versus 41.4, a clear difference numerically, if not, but not statistically, and that's the same also for a path CR rate too as well. But really excellent results in this trial, very high and superior outcomes, and a very high level of complete surgical resection, which were really excellent surgical outcomes, so perhaps very highly selected population, if I may suggest too as well. So takeaways really from neoadjuvant chemo IO, it's a new standard of care, but how do we fit it into our current treatment pathway guidelines? How do we select those patients who would have that pathway versus adjuvant, or indeed go to other forms of treatment? And that's going to be certainly an interesting point over the next couple of years as we develop national guidelines in this regard. What's very clear is pathological response rates, as have happened in other tumor sites such as breast cancer, predict very strongly for outcome. What's the optimal cycles? Well, 3 seems better than 2, which chemo can't say for certainty, but carbo may be better than cis. And what about the use of adjuvant IO afterwards? We just don't know that. And can you add in radiation to increase response rates? Perhaps more about that later on. Now, looking at back at adjuvant, this is looking back to the beautiful city of Chicago, and this was a very interesting adjuvant study to me. This looked at concurrent chemoradiation with platinum doublet chemotherapy, and patients were randomized to receive either nivolumab alone or indeed nivolumab alongside ipilimumab. And you can see this, the trial design as presented. This was a North American study by Durham et al. And the endpoint was 18 months progression-free survival, and there are a few other secondary endpoints on this. The really disappointing thing here is intensifying the immunotherapy by adding epi with nivo hasn't improved outcomes, and both for progression-free survival and overall survival there was no difference in either arm. Some suggestions as to why that might be. One is that the nivo arm alone performed really well and certainly seemed compared very favorably to the specific data too as well. But again, it may not, although you can't really technically compare these lines because it was a phase 2 study, I don't think you'll see that in a phase 3 study near us anytime soon. This now is looking at the Pearls Keynote 091 study by our wonderful Mary O'Brien from the Royal Marsden. And this again is looking at stage 1B to 3A non-small cell, completely resected, and then randomized to either pembrolizumab 3 weekly for 18 administrations or placebo. And you'll have seen this data elsewhere. Again, there was a improvement in disease-free survival with this particular treatment. Now, what this study was looking at the subgroup analysis and saying, were there subgroups that actually had a significant improvement? And the outcome from the study was that really that pembro adjuvantly increased disease-free survival regardless of the type of surgical resection you had, regardless of the degree of lymph node involvement or your tumor size, and indeed regardless of type or extent of neoadjuvant chemotherapy. So really, again, suggesting the use of adjuvant pembro in stage 1B to 3A if completely resected, and if recommended, that they've also had adjuvant chemotherapy too as well. Just a tiny poster came across, quite a curious one. This is a cotinib. It's a EGFR inhibitor made by a Chinese company, and this is just a early phase 1. But just to say, we've already had obviously a Jura, but there will clearly be a number of more later phase studies of other TK inhibitors coming in that space of adjuvant therapy in mutation positive non-small cell lung carcinoma. So one of my adjuvant takeaways is a single agent immunotherapy may be enough. There seems to be no benefit by combination therapy so far, but it's a phase 2. Pearls confirms a subgroup benefit across subgroups, and other adjuvant TKIs are on their way. A few little reflections that came in some of the discussions is, what about the timing of perioperative IO? Should it be neoadjuvant? Well, benefits are early you can get rid of micrometastatic disease early. That may change the dial. You have better and increased usage of IO because everybody generally gets it. Most patients complete and compliance is good. And you also can then find out more about how that patient's going to fare in terms of prognosis, as we saw earlier. Pathological response could also guide further intensification of therapy down the track. Of course, the big problem in the adjuvant, you can get progression, and the benefit of adjuvant, therefore, is you've gone straight to surgery and the tumor is out. There's no pre-surgery complications that may flow on, and you might get a longer treatment duration, enhancing that systemic control. And the benefit is regardless of subgroup, but it's unclear if chemotherapy is synergistic or additive in the adjuvant IO setting. So some interesting reflections that I certainly took away from that group. Or might you have both? That might be also the direction of travel too as well. Now, something of the night, as I say, both with surgery and radiation, and this, of course, Chicago at night time down the river, really beautiful scenery. But a few curious studies. This was a early phase study by Ori et al., and this was looking at giving induction pembro with PET-based hypofractionated radiotherapy. Quite a curious dose, 48 gray and 20 fractions, followed by adjuvant pembro by 36 weeks, and comparing that to thoracic radiation with carboplatin paclitaxel, followed by optional adjuvant systemic therapy of your choice. Now, we didn't get good outcome readings from this, but what we did was get feasibility, and I think you'll see this type of approach being used in chemoradiation studies, but with hypofractionation, it's quite unique to see, and I just wanted to flag that is coming down the track. Here was another very curious hypofractionated study, again this is from North America, and this was looking at comparing really giving durva alongside 60 gray and 15 fractions, which is much more hyperfractionated than we use here in the UK with our 55 and 20 regime, compared to giving durva alongside 60 gray and 30 fractions. This early phase study met its primary objective and showed it was actually safe to add the durva alongside the radiotherapy, but bizarrely in the standard fractionated arm, the 60 in 30, it did not receive its secondary objective because it was thought to be more toxic and had more treatment-related events. So it's quite interesting to see that. You'd have guessed it would be another way around before this study happened. And again, I think we're going to see a little bit more adventurous radiation regimes around either adjuvant or indeed concurrent IO coming along. I want to turn last to surgery. This to me was one of the most intriguing presentations at ASCO. This was presented by a surgeon working in the Veterans Affairs. Veterans Affairs treats around about 6 million patients across the US, ex-veterans and their families. And he had built basically a model to analyze their database. Their database is quite huge. And he was looking at the quality of surgery metrics. And this is looking particularly now at stage 1 non-small cell surgery. Looked at a number of different factors, things such as negative margin, were enough nodes sampled, what was their section like, did they do minimally invasive, was the surgery in a timely manner. And what he showed was that in terms of people having a good number of quality metrics, i.e. 11 to 12, only half the patients got that. That did improve a little over time, but still was not good in a very high quality healthcare system. But if you plot out those surgery metrics, and if you look at the slide, the blue line is 0 to 5 as a score, the top line is 11 to 12, it looks just like the staging atlas that we've had for non-small cell lung cancer for years. So therefore, quality of surgery has a huge impact. And this is stage 1. This is not even late stage non-small cell lung cancer. So we've put a lot of work into optimizing radiotherapy, put a lot of work into optimizing our chemotherapy pathways, our SAC pathways. Maybe we need to actually focus a little bit more on our quality surgery, and this was certainly a very much discussed presentation too as well. Following on, just it was a brilliant presentation, not new data, but from Nasser Al-Turki, who from New York, and he'd give a really interesting presentation about time to surgery. And we've got certain guidelines, but in the end, if he presented some curious data, said for every week that you wait for from your last intervention, be it neoadjuvant chemotherapy diagnosis, you lose about 3% in survival per week by waiting or delaying surgery. So timeliness of surgery has a real impact on outcome, and it's something we should focus on as a community. So takeaways: induction IO followed by hypofractionated radiotherapy and an adjuvant IO seems to be feasible, could be associated with good outcomes. Concurrent durvalumab appears to be challenging to complete, but is feasible in hyperfractionated. Quality surgery is highly associated with outcome, and timeliness to surgery is definitely associated with better survival outcome. Thank you very much, Tom.
Gary, that's magnificent. And would you believe it, we are bang on 45 minutes for the 3 talks. So that's fantastic, guys. Thank you very much indeed. So I can't remember, we've got a Q&A slide. I'm going to try moving the slides on one and see what happens. Maybe we don't, we're just going to chat among ourselves. So do send your questions through if you have any more to come through. I've got a few I've been scribbling down here madly. So the first one, Ali, is going to go to you, but I'm actually going to ask all of you guys in sequence, but do please feel to chip in. Ali, the TIGIT study, the very thing you opened with, with a lot of excitement about combination immunotherapies. We know that single agent Pembro can be fantastic, but it's not for everyone. It doesn't always work. TIGIT, another inhibitory pathway, inhibit that as well. There's a close association with PD-1 and PD-L1 pathway. Very negative study. There's also been a press release of a TIGIT and a TISO study in non-small cell, which is negative progression-free survival, though median, but we don't know, which is the primary endpoint, we don't know overall survival. Is TIGIT dead? I say that as someone who recruited his first patient to a TIGIT chemo IO study yesterday. Does it just show that small cells are very hard, or is it just far too early to say and hang in there and don't despair?
Well, so I think the first thing to say is I agree small cells very hard, and the immune environment in small cells is very hard. We don't see much of a tail with a single agent PD-1, PD-L1, or PD-L1, I guess, in small cell. Although, certainly I've got 1 or 2 patients who've done very well, and after 2 years on IO and with extensive stage small cell. So it goes to the fact we probably need to understand that biology better. But PD-L1 expression in small cells is relatively low. As you said, TIGIT seems to work on a similar sort of axis. So this may not have been the right checkpoint. It may not have been the right immunotherapy, but I'm not convinced adding in another checkpoint in small cell is the right thing to do. We've seen previous studies with Nivo/Ipi that haven't done particularly well either. Is TIGIT dead? I don't think so yet. I think the jury's out. I think it's taken a big blow. It's staggering. And I think actually the press release that you mentioned was probably a bigger hit to it, although we need to see that data, but it doesn't marry up to the Cityscape 2 that we saw at ASCO either last year or the year before that showed a big improvement in progression-free survival by adding it in the high PD-L1. So not dead, but weakened.
Yeah. On level 1, on non-invasive ventilation.
Tom, if I can come in,
please do.
Probably the most negative feedback I ever saw from a presenter about his own drug. He was quite clear it definitely was of no benefit whatsoever. And it was quite stark, not even subgroup analysis. His answer was no to every question. It was quite astonishing for a meeting,
Yeah, it's true. You're absolutely right, Gary. And Riaz, I wonder if I could pick up on something. So Ali alluded to the fact there was some criticism in the discussion and sometimes on a bit of social media afterwards that this was a phase 3 study without any phase 2 data, the small cell. Maybe they should have done a phase 2 to save money, but most importantly, save patient recruitment to a trial that is not going to be effective. But then we've had lots of studies like the non-small cell where you've got a positive phase 2, but actually the phase 3 doesn't pan out. Should we be doing phase 2s always before doing phase 3? Is it justifiable to go straight to a phase 3? What's your thought on that?
Yeah, it's really interesting, isn't it? I don't really have a view on it. I'm intrigued that there are licensed drugs out there now in small molecularly sub-targeted NTRKs, a great example, based on no randomized data at all. So at one level, we accept very early phase, if you like, data in certain situations, and in other situations we change our goalposts and say we want big randomized phase 3 studies. Look, the TIGIT thing is really exciting. I think everyone just needs to keep calm and just see the data as it comes out, because these trials, yeah, they're running, but actually a lot of them are close to accrual and we're just waiting for readouts. So I think it was what Alistair said about Cityscape and the high PDL1. I mean, it was a profound difference. And so it would be shocking if that didn't translate into some sort of phase 3 bigger trial difference. Yeah. It would really kind of raise doubts about phase 2 studies in tertiary centers of excellence, and are these patients even representative of lung cancer patients at all?
Yeah, that's very helpful. We're now going to move to one of Jerry, one of your subjects and areas of questions coming about that. So we saw an update in Checkmate 816, which I think is one of the most important studies for a long time. As they say, it's a paradigm shift. We must always say paradigm shift as often as we can. You talked about the study with concurrent chemo-rad followed by niv-ipi, which was disappointingly negative, although the nivolumab arm, control arm, so to speak, not really control arm, but you know what I mean, overperformed. But interestingly, one thing I saw in ASCO was the NeoCo study, which was niv-ipi as a neoadjuvant treatment with a suggestion of a better pathological complete response and major pathological response. So actually there's a suggestion that neoadjuvantly, maybe combination chemo immunos, niv-ipi, may be better. Who knows, it's all cross-trial comparison. But actually in the after chemo rad, doesn't appear to be terribly helpful. What do you think the future is of trying to combine agents and immunotherapy agents, particularly the concern we'd all have about radiotherapy if we're going to be doing that, and surgery if that's planned as part of a neoadjuvant setting?
Tom, is a really great question. I think, there's two things. I think one is when you've got chemoradiation as your initial therapy, you've got such a really priming of neoantigens. You've got a really hot tumor environment. Therefore, I think it's not unsurprising that that nivo-ipi combination is negative, simply because you've got all the immune stuff going, and therefore picking up by one agent is probably might be enough. That might be the reason why that's potentially negative. It may also be the wrong agent. Nipo-ipi may not necessarily work in non-small cell in that way. While it's in the neoadjuvant, but you've got quite a cold tumor biologically speaking, therefore you might need more of an immune blockade to get going. That might possibly be the reason. I think there's so many unanswered questions. I think we've got at least a good decade of trials to say, look, how do we optimally sequence things? How do we compare various groups of people? There's even getting a good marker of response is really challenging. I do think the neoadjuvant studies do give us a lot of very intriguing information because of the pathology that comes out of that, and we can maybe analyze that into a lot greater detail. So it's, I mean, you think you've got somewhere, but really we're only beginning to work out how that would be, and it'll change dramatically, I think, over 10 years. So trials, and more trials again is the answer.
All right, yeah, please do.
The stage 3 setting is about to become a mess in our MDTs. It's going to become very challenging. Because the trials aren't directly comparative, and a lot will depend on things like whether a surgeon thinks it's resectable. There may be individual variation with that. So I think it's very important that we bring all members of the MDT at least up to understanding these trials and thinking about how the patients fit into them, and then trying to at least develop a consistent practice whilst we wait for other trial and capturing our real world data. We need to work out what's happening as we start to use these agents in our patients.
Yeah, and I just touched on that. I don't want to touch on that. I think we should all do real world data, and certainly in BTOG we're very keen to do national real world data studies. We've had success in doing that so far. So if anyone's listening and wants to be involved in a real world study, do let us know. Riaz, just to touch for you quickly, there was something in BTOG, in ASCO, which I can't actually remember the abstract, but it was looking at ctDNA clearance from the NADIM-2 study. NADIM-2, just to let people know, is neoadjuvant niv-ipi surgery and then adjuvant nivolumab for 6 months, showing that if you clear your ctDNA quickly, you do better and you have a better outcome. Can you see a situation where you're going to be starting your patients on neoadjuvant treatment and doing their ctDNA, seeing if they're responding? If they're responding, well, then that's super. And if they're not responding, you're going to escalate up? Or is this pie in the sky for quaternary cancer centers in West Coast America?
No, I don't think ctDNA is quaternary stuff at all. It should be standard of care. I know of at least one manufacturer of ctDNA that is recognized as an NHS approved entity, but the reality is that most trusts have not decided to commission it or don't understand it. It's a terrible, terrible situation we're in, where many patients are having to self-fund it. I think ctDNA, I alluded to the importance of ctDNA in initial diagnostics, that if you combine ctDNA with tissue NGS, you're more likely to pick up clinically relevant mutations than doing just tissue on its own. So that's one big role for ctDNA. You're talking about MRD, minimal residual disease, and I think that's another stream where ctDNA is almost certainly going to have a role in prognosticating patients who've completed some sort of curative therapy, as to whether they need dose escalation or surveillance. But, you know, all of that needs to be tested in randomized trials. You can't just assume that a ctDNA readout actually means anything clinically relevant without testing it in a prospectively designed study. So there's a huge, as was alluded to earlier, you know, we've got 10, 15 years of trials that we need to sort out.
Absolutely, that's very helpful. Thank you. I'm going to move on in our last 3-4 minutes onto KRAS, which is obviously very important. We now have a drug available. I loved your little picture of what's available across the various parts of the United Kingdom. It's not good enough that there is that variation. But sotorasib, whatever you want to call it, is available. It's available, I think, in most bits of the UK after platinum-based chemotherapy. The adagrasib data, can't say that. I thought that was a bit disappointing, Ali. What do you think? I mean, I think we were rather hoping that ADA was going to be a bit better, have a slightly longer progression-free survival than the kind of 6 months you've seen with sotorasib, but actually it's kind of bang on the same thing. Were you disappointed, or were you cheered by the brain data?
No, I was disappointed. You know, I think sotorasib and adagrasib, you know, they give good responses, but the response length of time is not long enough. The response rate is not high enough, and they were very similar in terms of efficacy, and some suggestion that the toxicity might even be slightly worse. And certainly taking a tablet twice a day fasted is far more difficult for my patient group. There were lots of posters out there about some other agents coming through that have different mechanisms of action, and that's probably a subject for another day, but hopefully we will see new agents coming through. But this is still a major advance on what we had a year ago. You know, we'll be presenting our BTOG real world data together at ESMO, and I can tell you that the real world data does match the trial data, which is lovely.
That's very fun. I'm going to ask one more question. Riaz, a second question come through. Just, Jerry, someone's asked if they can have the reference, the abstract number for the timeliness to surgery data. I don't suppose you've got that. Sure. You could just dig it out and shout out in a minute or so. Riaz, what do you think the future of combinations are for KRAS inhibitors? Because quite clearly by themselves, they're a bit disappointing. I mean, they're fine, but they're not TKIs. We should not expect them to behave like TKIs. They're not the new osimertinib. Some people have talked about immunotherapy combinations, but there is a concern, I understand, about hepatic toxicity, maybe, that combination. People talked about SHP2 inhibitors joining in. Do you think we have an idea where we're going to go, the future of KRAS inhibition?
So I think right now the focus is going to be because there are different classes of inhibitors. So these two inhibitors, adagrasib, sotorasib, are off inhibitors. There are on inhibitors. There are other inhibitors that are being developed for different KRAS mutations, different allelic subtypes of KRAS, and there are even pan-KRAS inhibitors that are in clinical trial development, like Boehringer have one. So and there's a company called, I think it's called Regeneration Medicine, that has some really cool KRAS inhibitors. So what we need to work out first is, are any of these better? Is an on inhibitor actually better than an off inhibitor in real clinical practice? Does it offer anything over and above sotorasib or adagrasib? So I think that's going to take us 2 or 3 years to work that out. And then we need to work out combinations. whenever you start combining drugs, it's always overlapping, particularly TKIs and immunotherapy, overlapping toxicities, renal toxicity, hepatic toxicity, pneumonitis. So, there's a huge journey. We've taken one step, and with adagrasib, half of another step. That's it. There's a long, long way to go. It's hugely fascinating and such a common mutation in lung cancer. We've got so many patients with KRAS mutations.
True. Last question, just to the person who asked about the reference for timeliness. It's Korami. I think Jerry's just put in. Altorki, Altorki, was the lead author, ASCO 2022. And you can find that on the ASCO website. Last question, Jerry, to you, and then I think we're out of time. Atezo brain, the data that Ali showed us, brain metastases in lung cancer is so common. Often these patients excluded from clinical trials, often from a blue tech form, certainly in England and Wales, often excluded from treatment if they're symptomatic. What did you take home from that? If you had a patient with a brain metastasis, does that give you reassurance that chemo IO is going to be an effective treatment? And how do you involve your neuro-oncology team in your patients with brain metastases?
Yeah, that's a really tricky one, Tom, because we don't have a good treatment paradigm here. And one of the other problems is, obviously, in the radiation side, we've made a lot of progress with stereotactic radiosurgery, and we could get really good local control. One of the problems is obviously combining stereo with IO. You can get a lot of enhanced, intracranial toxicity, and that's the challenge. If you've got somebody with, asymptomatic brain mets, they're small and they're doing really well, and they tezo chemo, you may well keep them going in that. And I don't think you have a cut point, but if you've got at-risk metastases or heavy somewhere near an area that could go wrong, and they're not on drug, you might get the SRS in before you do treatment. So I don't think we know how to sequence those patients, but just to bear in mind that SRS is a really good treatment for it, particularly if you've got only 2 metastases inside the brain, and we don't know. Of course, we've really moved away from whole brain radiotherapy. It's almost a thing of the past, particularly in non-small cell. Still use it occasionally in small cell, but I think again, with this really big improvement with IO, really being very effective inside the brain, we may see a real fall away in radiation use in that sense. But don't throw the baby out with the bathwater, Yeah.
Definitely never do that. I think that brings us to the end. Matt, if we could just move on to our last slide, just with the details of upcoming BTOG webinars. I'd like to thank my colleague Ali Greystoke, Jerry Hanna, and Riaz Shah for all their work and effort. It's Herculean to do this. It's very difficult to try to pull this data together, so I'm extremely grateful for them for doing so. Our next webinar is in September, so you've got a couple of months off, guys, to enjoy the weather, and that's going to be the World Lung and ESMO updates, which a certain Professor Popat is going to be hosting. We very much hope everyone online is going to be joining us for the BTOG summer meeting, which is about 2 weeks away. So please do come along to that. I think it's going to be fantastic. There you go. You can still register, and you've got dates there. And we've also got the mesothelioma essential update, which is in when is that? That's in December. That's a while away yet. So have a look on the website. Have a look at those. Thank you all for joining us, and we hope to look forward to seeing you in a couple of weeks at BTOG 2022. Bye bye.